Any question from the audience?
Yeah.
So are you changing your LDL target for secondary prevention?
I would be, I'm a practicing cardiologist, and I see so many patients with severe coronary disease, bypass patients, stented patients. They come with an LDL of 150. So I would be so happy if we could reach the goal below 70. But in those rare patients who are well tolerating the drugs and they have an LDL cholesterol with 60, I can show them the data and discuss it together with the patient. And if we have to increase the statin dose, probably yes. But I would not personally go to PCSK9 inhibitor just to come from 72 to 50. That's not worth it.
How could we explain the different results in COMPASS in stroke, peripheral arterial disease, and myocardial infarction?
What do you mean exactly?
Exactly that there are very, very good results in stroke with a reduction near 50% in COMPASS, and no as good results in myocardial infarction, acute myocardial infarction.
Well, all I know is maybe the dose is too low to inhibit the thrombin even stronger. I mean, the concept of the whole thing is that the inhibition of thrombin inhibits also platelet activity, and maybe you need higher doses, but that's just speculation. You need higher doses of anticoagulation to inhibit stronger the platelets. But again, I don't know, that's speculative.
Thank you.
Dr. Grundtvig from Norway. I just have a comment about the Condensed study. The trialists claim that about 40% of patients have CRP more than 2 after myocardial infarction. Now, we did this very systematically. We took everybody who was coming to follow up after myocardial infarction, and we had many patients, and we could only find 10% of the patients with a CRP more than 2. So this is a subset of patients targeted for this possible drug.
Yeah, maybe, yes, I think you're right. Maybe the longer you wait after heart attack, the lower the CRP, maybe. But
we had them 2 or 3 weeks after for a follow-up.
Yes. But again, this therapy is new. We have to learn a lot about it. I think it's exciting. But again, the inclusion criteria was a CRP higher than 2.
I am old. I am remembering some trial about cortisone in the 70s, and they were not so good. So we have to choose also the appropriate way to do anti-inflammation. Yeah. Aspirin itself is an anti-inflammation.
Well, in the old studies, they didn't have...
We have a lot of things to learn about this topic. Please.
In the COMPASS study, aspirin plus rivaroxaban clearly beat aspirin alone, but I'm not sure that it beat rivaroxaban alone, and they actually didn't do those analyses, and I was just wondering what you thought, because we are left in a quandary now that rivaroxaban alone didn't seem to beat aspirin alone, but the combination didn't seem to beat rivaroxaban alone.
Well, there was a rivaroxaban alone group, but this was a higher dose, two times 5 milligram, yeah.
But it wasn't inferior to the combination.
Yeah, but I still believe in aspirin. So
why?
Why? Good. Because
what evidence do you have? Because there isn't a long-term trial of aspirin showing a reduction in mortality.
I know, but aspirin and DAPT is the key of
it's just
all
tradition.
Traditional cardiologists.
Yeah, okay.
Plus, I mean, many people thought that COMPASS will kill aspirin. That's what I was told before, and COMPASS did not kill aspirin because...
No, it's very resistant.
It is resistant, yeah. So maybe it's a good drug, you know.
Okay. So, thank you for coming.